Good afternoon, Chairwoman, and good afternoon, committee members. Thank you for the invitation. Just by way of background, my name is Jim McCreath. I'm the Vice President for Behavioral
Thank you so much.
Medical Center and St. Joe's Health in Patterson. We have a partnership for behavioral health. I've been at Trinitas for 4 years, but I've been in New Jersey's mental health system for 40 plus years and was the president and CEO for a number of years for a community agency providing the very services we're talking about today. I have a doctorate in social work and a licensed clinical social worker, and thank you for mentioning Social Work Month. By way of introduction to Trinitas, Trinitas is the name given to the consolidation of Elizabeth General, St. Elizabeth's, and Alexian Brothers Hospital in Elizabeth, New Jersey. This was around 2000. Elizabeth General Hospital has a long and distinguished history of providing community mental health services going back to the 1960s, and we have an enormous array of services that have continued after the hospitals consolidated. Our first our first program for this population started in 1997. It was funded by the Division of Developmental Disabilities, and it was meant to provide follow-up services to individuals discharged from developmental facilities in the central region of New Jersey. With the funding that was available, there were 4 staff who provided follow-up care, mostly in the central counties. In 1998, the Division of Mental Health and Addiction Services funded what we labeled the statewide clinical consultation and training, a SCAP program. At that time, the program went statewide, provided services throughout New Jersey, mostly consultation and training. So they were really working with agencies that were providing services to this population, and that continued. Those 2 funding streams remained separate, but the programs were integrated operationally, and that continued until 2015. In 2015, the division rebid those dollars. Trinitas applied, and it was reawarded that funding in December of 2015. And at that time, it was called CARES, Crisis Assessment, Response, and Enhanced Services, which is what's operating today. Basically, the program operates out of 5 locations throughout New Jersey. We cover all 21 counties in New Jersey. It's a multidisciplinary team of 24 full-time equivalents. There's an annual budget of $2 million. We serve approximately 1,300 individuals in just this population, just this dual-diagnosed population a year, and provide approximately 1,000 face-to-face evaluations, mostly in screening centers or emergency rooms, but it can be homes or group homes. There's a statewide access phone number, one number for the entire state. The program operates 24/7 times 365. We're able to go out any time of the day, evening or weekend. In 2018, they delivered over 7,000 phone consultations in addition to the 1,000 face-to-face consultations. The program uses an electronic medical record throughout the state that when the staff are out in the community, they're actually documenting on a laptop in our EMR, so we have a pretty good database on the folks that we serve. In 2016, we started using Echo Technology. That's a web-based program licensed by the University of New Mexico. It's not tele in the sense that there's any billing. There is no billing. But it provides for the opportunity to do live case consultations where family members, as long as they have a cell phone, an iPad, a computer, a laptop, they participate in that live discussion, that live video discussion, where we're doing a consultation with usually an expert and the individual themselves and, of course, our team. In 2018, CARES did 170 agency trainings and 7 regional trainings. The measure of success for CARES is to keep people out of screening centers. We try to educate agencies to call us as soon as possible so that the individual doesn't have to be introduced to a screening center. But, of course, if they are, we will go to every screening center in New Jersey to evaluate them. And the other measure of success is to ensure that only the most appropriate people are admitted to our inpatient program. And that's our second service. We have a 10-bed unit dedicated only to this population. No other person is admitted to the unit. It's the only one of its kind in New Jersey that we know of. It was established in 1999. We usually admit between 270 and 300 individuals a year. The length of stay is roughly 11 days. So in 2018, we had 87% occupancy, delivered just over 3,000 days of care. The vast majority of the individuals on the unit are discharged back to their community residents. And of course, the goal is the stabilization of the admitting crisis. It's a multidisciplinary team. It's a very intense staffing. Almost everyone on the unit requires one-to-one, 24/7, and many individuals require single-room occupancy. Oftentimes, as you've heard this afternoon, the behavior that caused the admission results in the individual being evicted or eliminated from the setting that they were living in, which does create a very, very difficult disposition problem for us. And individuals can stay for a number of weeks. Just a word about the limitations of general psychiatric units for this population. And we do know from our data that about 250 individuals who are dual diagnosed, but perhaps a little less complex, are admitted to short-term care facilities throughout New Jersey each year. The primary tool of inpatient psychiatric inpatient units is medication. And medication has a limited effect with this population. More often than not, when individuals are admitted to our unit, we reduce or eliminate the medication that they're on. And the other issue with inpatient psych units in general is that they rely on group therapy and individual therapy, and that has a limited impact on folks that, or limited benefit on folks that are limited verbally. Our primary focus on the unit is really behavioral analysis. That's where we do the work that allows individuals to stabilize and return to the community. But we recognize that follow-up care in the community is really critical, because if we send someone home with a behavioral plan and that plan isn't followed precisely, then more often than not, the behavior is going to be undone. And the individual will be back in an emergency room or out of that residential setting, whatever it may be. Our recommendations for improvement in the system, and again, I really appreciate the opportunity to present these, the caretakers in New Jersey need enormous support. They need caretaker support, they need respite, they need education, they need case management, they need advocacy. They take on an enormous burden in serving their own family members or their relatives, and they need tremendous support. Individuals transitioning from the high school to the community, that handoff is very awkward. There's a lot of institutions that are involved. The schools are somewhat involved. That needs some streamlining so that individuals who are getting ready to leave school and come into the adult community get a better handoff. We feel strongly that ECHO funding should be expanded to allow us to engage experts from around the country to be able to do live video conferencing on very complex individuals to get their input. And again, this is live, it's video. Family members can participate in these meetings, and it's very low cost. And again, ECHO consults are not something that can be billed for. We feel strongly that our CARES program would do much better if it morphed into a pack-like team, one for the North, one for Central, and one for perhaps Southern Jersey. And the teams have to have certified behavioral analysts as part of the team. We also feel that New Jersey should explore the opportunity to develop an accountable care organization like model or a behavioral health home model that would include primary care, dental care, and vision care for this population. We do agree that an additional unit is needed in New Jersey. We have 10 beds, and that is not enough. And you're hearing this afternoon about long delays in the emergency room, and we certainly understand that. But again, we have 10 beds for the entire state of New Jersey. We also feel strongly, and there are models in other states, of intermediate stay neurobiological units that can work more in the area of behavioral analysis over a longer stay, 15 to 25 days, where the individual can really receive the attention they need from a behavior analyst and have that plan put into effect. And again, there are units around the country that certainly could be a model for that in New Jersey, and we think 6 to 10 beds in New Jersey would be adequate for those individuals that would be referred to the unit for that additional attention. And again, I thank you, and certainly will take any questions you may have.